Boa tarde a todos. Temos a satisfação de termos aqui, de promovermos, né, o Grupo de Pesquisa em Estomaterapia da Escola de Enfermagem da Universidade de São Paulo, sob coordenação da professora Paula Nogueira e minha, professora Vera Santos. Nós temos a honra, então, de promovermos mais uma aula aberta internacional com o professor Kevin Wu, professor da Universidade da Queen's University of Kingston, no Canadá. É uma pessoa que tem feito parcerias antigas já, desde muito tempo conosco, com essa escola, com o nosso grupo de pesquisa, com o programa de pós-graduação em enfermagem na saúde do adulto. Então, tem todos hoje o tema do professor Kevin será sobre MASD e MARSI, falar um pouco de alguns desafios que acometem esses dois tipos de lesões. E muito nos honra, então, termos o professor Kevin, que está novamente no programa de professor visitante nesta escola. Professora Paula.
Sejam todos muito bem-vindos. É uma honra, sim, ter o professor Kevin aqui novamente. E aproveitem bastante a aula. No final, nós abriremos para comentários, para perguntas. Muito obrigada.
Vocês podem, inclusive, no chat, é possível, gente, do YouTube, é possível fazer perguntas. Então, vocês podem, inclusive, fazendo as perguntas já durante a apresentação do professor Kevin, tá bom? Obrigada, pessoal. Desfrutem aí da aula do professor Kevin. Professor Kevin, be with us again.
Let's see.
Restaurou.
Okay, so thank you so much, Professor Vera and Professor Paula, for the invitation, and thank you so much for the research group and such a kind introduction, and allow me to talk about a topic that we've been working on for the last couple of years. So the topic I want to share with you today is focused on MASD, moisture-associated skin damage, and MARSI, medical adhesive-related skin injuries. So the objective for today, I'm going to take a look at the relationship between pH and the mechanism, how skin pH can actually prevent or expose people to the risk of developing MASD. I'm going to take a look at the best practice around skin hygiene. A lot of you may be familiar with the document, the best practice document on skin hygiene already, but I want to extract a few key points that I want to share with you today. And I'm going to appraise and talk more about some of the evidence-based practice on MASD management. And I'm going to talk about, there's a project that we're quite excited about in collaboration with our Wound Care Association, the nurses specialized in wound ostomy and continence, in developing a scale to evaluate the intensity or severity of MASD. And then at the end, I'm going to highlight some of the key evidence around medical adhesive-related skin injuries. So I think the more I think about the different types of skin injuries, the more I think that when you look at all the risk factors, they share a lot of commonalities. Perhaps we need to look at a different paradigm that all those different conditions are not so discrete. When we think of pressure injuries, people have pressure sores, but we always have to think about those individuals carry the same risk factors for developing MASD, skin tears, and MARSI as well. So I'd like to describe all those different types of skin injuries on a continuum, from a risk skin to maybe perhaps more minor skin problem or superficial skin problems like MASD and MARSI. And then if things are not being done correctly and treatment is not implemented promptly, then those individuals can develop pressure injuries and eventually even skin failure. That is another very popular emerging concept. So I think the idea is by describing all those conditions, skin conditions on the continuum, we can think about the need for prevention at an earlier time by identifying people at risk for skin problems. If we put all the interventions we describe in the literature as skin bundles, it's not one intervention or certain interventions that is particularly customized for pressure injury, but it's a whole spectrum, battery of interventions. We can prevent all the other problems from happening, perhaps. And I think we need some validation to confirm that, of course, in the future. So you can see that when things get more involved and you get more advanced type of skin problems or injuries, then more diligent and deliberate treatment protocols may be required to address some of those problems. So let's come back to talk about MASD, moisture-associated skin damage. Just want to review with you a few facts about skin pH and healthy skin. As we're all aware, healthy skin, there's a acidity level that is required to maintain skin integrity and optimal function of the skin. And usually the skin is around 5.5 pH level. So it's quite acidic. And if you look at the literature, they describe that our skin is not homogeneous. It depends on the location. There are different levels of pH. And you can see on the slide, perhaps it's quite small, but on the front of the body, on the bottom of the feet, for example, the pH is a little bit more alkaline. It's about 7.2 versus some other areas on the face is about 4 point something. So different areas will have different pH level, but in general, it's 5.5. Why I want to point this out? Because when there's changes to pH, certain area may be more vulnerable to a small change in the pH. For example, if you use an alkaline solution to wash your feet, that may not be a big problem, versus you using alkaline soap to wash your face, that may be more irritating. So the pH may depend on the anatomical location and also depends on the type of skin tone as well. We know that a lot of individuals with darker pigmentation on the skin because of the melanin, because of different types of sebaceous gland. In fact, Black people tend to have more acidic skin compared to whiter skin. So perhaps, again, we need further research to determine whether because of the differences in pH, making certain race groups more vulnerable to certain type of skin problems. And by maintaining the acidity on the skin, we can actually enhance the skin integrity. A lot of times when you look at the literature, they describe the skin architecture arranged in a brick and mortar kind of arrangement. This is a very sort of an interesting, very exquisite, very elegant type of arrangement that prevent irritants and chemical agents to invade directly from the surface of the skin to the deeper compartment of the skin. So because you can see that it has to go through a very sort of meander through this pathway in order to get to the deep layer. So this is a very important configuration of the skin to maintain. And in order to do so, we need a very low pH acidity level. In addition to that, low pH is crucial to maintain the normal type of bacteria, what we call the skin microbiome. And I'll come back to talk more about the implications of microbiome and wound healing, and also looking at how to promote better skin health as well. So the acid mantle definitely is very, very crucial to help maintain the skin integrity. The type of sebaceous glands and amino acid in the sweat has a role to play to maintain this acidity. So what if we change the pH? We also have identified research out there suggesting that with alteration in pH, you can actually change the bacterial proliferation on the skin level. Bacteria prefer to grow in an alkaline environment. In wound care, in wound care type research, we know that biofilm tends to establish themselves in a more sort of a friendly alkaline environment, versus when we create an acidic environment that tends to stop the bacteria from growing and tends to be more hostile to biofilm formation. So why pH matters? I think this is a very, very busy diagram just to illustrate all the different components of how the skin maintains pH and the outcomes with the normal skin pH level. You can see the fatty acids, the phospholipids, and the different layers and sebaceous glands. All those production of essential amino acid is able to maintain the skin pH, and ultimately the outcome that we're interested in is the establishment of a normal microbiome and the normal skin hydration level, and promoting normal cell desquamation as well. So what can change the pH of the skin? No big surprises, I think, for a lot of wound care specialists can really articulate this very well. As we age, with the reduction in sweat and oil production, of course, we're more at risk for developing alteration in skin pH, and that's why they're more vulnerable to develop skin tears and MARSI and MASD problem. And think of all the other areas that have folds. Because of the sweat accumulation, moisture accumulation, that can dilute the pH level, making it more alkaline. And we often see dermatophyte fungus and other type of bacterial growth in those areas for the reason that we change the pH level to more alkaline. And this is a nice little diagram just to show you that the normal microbiome is so vital as a defensive mechanism to protect the skin against some other more dangerous pathogens. By wiping out our microbiome, it can actually enhance the opportunistic bacteria to grow on the skin that potentially have a severe damage to wound healing process. So, our main topic, moisture-associated skin damage. And often we think about irritant contact dermatitis in relation to incontinence. And of course, as the terminology continues to evolve, we capture other type of problems in addition to incontinence related to dermatitis and skin damage because of the exposure to urine. But also we see that damage to peri-wound skin. You can see that the area is quite macerated. We can see that area in the intertriginous region, in between skin folds, where there may be a lot of moisture accumulation, result in different types of skin damage. IAD, of course, that's the major presentation of MASD, and not to forget about the peristomal type MASD around colostomy, ileostomy, even feeding tubes or tracheostomy patient as well. So this is a very simplistic diagram to illustrate the pathophysiology involved in the development of, particularly in this case, IAD, with exposure to moisture, in this case, urine or fecal material. In the urine, there's a lot of urea that can be converted into ammonia, alkalizing the skin surface, making the skin more permeable, damaging and disrupting the arrangement of the skin configuration that we have talked about earlier. So now the skin is weakened and more likely to to be subjected to damage from pressure and shear. At the same time, because of the change in pH, there's a disturbance to the microbiome, allowing certain type of bacterial growth to occur. So you can see that they all come together in a common pathway, causing some serious damage. And that's why people who have IAD, we know that they're more at risk for developing pressure injuries. And this is one of the slides that Professor Bakeman had developed with his group, really highlighting the knowledge of the separation, differentiation between IAD and pressure injury at that time. I think as we continue to evolve, hopefully we'll be more sophisticated in how we describe the nuances between IAD and pressure injury over time. And the skincare that is required to maintain skin health is to protect the skin early, prevent bacterial invasion, and we want to avoid alkaline soap, avoid too much friction on the skin that can damage the fragile skin. And also, we want to apply regular moisturizer in order to maintain the hydration level. At the same time, we want to select the moisturizer that has the correct formulation with the right type of hydration product, humectants, and also the pH level. So there are a variety of products, and I'm not going to belabor on this point because a lot of you are quite familiar with what you have in your country, in Brazil. And in my country, in Canada, we have very, very popular choices is the zinc oxide. We find that sometimes it's very difficult to remove the zinc and resulting in a lot of trauma and friction problem. And so alternatively, we can use dimethicone, and the sun acrylate and acrylate material has been very, very popular as well to protect like a second skin to offer protection. So I think in order to maintain healthy skin, I think we still have to apply a wound paradigm, a wound hygiene paradigm, even though originally it was developed focusing on ways that we can improve wound healing. But in order to prevent MASD, prevent MARSI, I think we have to think about how we can address the cleansing process in a better way. But for people who are not familiar with this paradigm, this model, it's developed by Chris Murphy and her group, talking about the 4-step approach to wound hygiene, cleansing, debridement, refreshening, and antibiofilm if you have a wound. So the most important component, as I mentioned, is the cleansing process. There's a lot to reflect on in terms of the cleansing technique. And what you see here, whether it is dribbling, moistening the wound with a few drops of fluid, or using a jar or bottle of water to pour over the wound, even some of the soaking and wiping, there's a lot of questions and challenges around whether we're generating enough pressure and enough fluid to actually adequately clean the wound and cleanse the wound. And over the last 5 to 10 years, there's a number of really good documents promoting some of the best practices. More recently, there's this document, Therapeutic Wound and Skin Cleansing, Clinical Evidence and Recommendations. If you're not familiar with it, I encourage you to read about this document. There's a lot of good recommendations and highlights, including some of these slides that I'm going to share with you today. There are a variety of techniques involved in wound cleansing. You can irrigate a wound, you can swab the surface with a gauze material or some other type of microfiber. We can do something like a cleansing pad or microfilament fiber pad. We can compress using a saline gauze, usually soak it with the solution and apply on the wound and leave it in the wound for about 5-10 minutes. The idea is allow the fluid to be saturated into the tissue so we can facilitate the cleansing process. And there's also other potential methodology involving soaking and bathing, although we don't really recommend soaking and bathing that much because of the fear of cross-contamination and colonization. Installation therapy has becoming quite popular with the promotion of different types of negative pressure therapy with this capacity to instill into the wound and at the same time remove the fluid promptly, along with it all the necrotic material or non-viable tissue on the wound as a cleansing process. And last but not least, we also have some of the hydro-responsive dressings as well. So recognizing the importance of wound cleansing as a very, very important step as prevention, as an active wound treatment modality, we did a survey in Canada asking our wound specialists, our ANSWOCs, what is their routine practice and preferences in terms of wound cleansing. So we raised a few questions. I'm going to share with you a few answers here. As part of the routine care, what solutions do you use for wound cleansing? So it'll be interesting for you to do a similar study and see what the Brazilian nurses are actually doing. And no big surprises here. The most common solution used for cleansing is saline solution. What surprised me is following that option, the second popular choice is the use of hypochlorous acid solution. Now, this study is promoted by a company that manufactures hypochlorous acid at the same time. So perhaps the sample size is slightly biased. That's why we see the hypochlorous acid being the second choice. And then you see a variety of different products. I'm actually surprised that soap and water is chosen as one of the relatively popular choice. And you also have acetic acid and other solutions. PHMP in our country is not extremely popular because of accessibility issue. It's a little more costly and not all the formulary has PHMP available for nurses to use on a routine basis. And another question we asked, what are the top 3 factors that you would consider when choosing a wound cleanser? And this is no big surprise to us as well. The choice is based on availability, depends on the presence of infection, and also the whether there's evidence available for them to substantiate the practice. So I think it's interesting that people place evidence at such a high level, and it really present a big challenge for company when they promote different products, at the same time present with the evidence to support the use of their cleanser or different dressings as well. So, and I don't want to sort of spend too much time on this slide, except that we know that a lot of people agree wound cleansing is important. Maybe perhaps in the future, we can even develop some type of a knowledge tool to ensure that people have the competency in terms of performing and executing wound cleansing with a more scientific way. So what you can see here, there's a lot of disagreement about wound cleansing as in reducing biofilm and prevent wound infection. So perhaps there's a lot of, I'm going to show you some evidence in terms of depends on the type of wound cleanser. There's certain type of wound cleanser, the ingredient perhaps has a role to play in preventing, reducing biofilm and preventing wound infection. So do you agree with the following statement? No big surprises here. Most people agree that we need to clean the peri-wound skin. Antiseptic agents should be used to clean the peri-wound skin. I don't know what your opinion is in Brazil, and perhaps it's quite debatable, and it will be interesting to have a discussion and dialogue about this particular issue. Should we continue with saline, or should we start thinking about using antiseptic, antimicrobial agent to clean all the pathogens and bacteria around the wound? Because when we look at some of the imaging devices, when we did the analyses, we found that there's a lot of pathogens, the proliferation of bacteria are primarily in the peri-wound skin, not necessarily in the wound, on the wound surface. We also want to, there's some interesting comments about soaking with the gauze and the mechanical scrubbing as the best way to clean the wound. Perhaps it is not the best way. There are other more sophisticated, better way and less messy way to clean the wound. So what is the consensus document telling us Dribbling, moistening the wound is no longer considered to be adequate and best practice for cleansing a wound. We need to be more aggressive. We need to generate enough pressure into the wound environment in order to clean the debris and bacteria. Now, alternatively, we can also use a soaking method, but we have to make sure the dwelling time is adequate enough to allow the cleaning process to occur. And I think the most interesting and most informative piece of information on this document is the discussion about adequate volume of solution that is required to clean a wound. So it's estimated to 50 to 100 cc of fluid per centimeter of wound length for a wound for adequate wound cleansing. In other words, if you have a wound that is, let's say, 10 by 10, you need about a liter of fluid to clean that wound, to be adequately cleansing the wound. I can't remember when's the last time I actually used that much of solution to clean the wound, but it's really promoting the idea that we need to use adequate amount of pressure, adequate amount of fluid to clean the wound thoroughly. Because, and I'm going to come back to talk about this point, it's not just about the local wound cleansing, but also the per-wound cleansing as well. And also in this document, they talk about the traditional cleansers. Some of the cleansers are very, very cytotoxic, definitely no longer recommended. For example, hydrogen peroxide, sodium hypochlorite, povidone. We don't really recommend those. In the wound environment, and we're using the molecular light, and a lot of you are quite familiar with this fluorescent imaging device, and we're able to identify the bacterial growth or the colonies actually established not necessarily along the incision or inside the wound, but they're in the periphery, in the peri-wound skin, and that's why cleaning the peri-wound area is so vital to be part of this wound hygiene concept. And this is a very interesting study done to demonstrate the point why we need to challenge the notion of using saline as a gold standard of or usual practice to prevent infection. You can see there's a lot of fluffy tissue. It doesn't look extremely healthy. Versus after when we use the molecular light to look at the wound, there's not a lot of bacteria. You don't see a lot of red discoloration indicating heavy bacterial growth. However, after cleansing with saline, you can see the colonies of bacteria in red discoloration. You wonder, well, I cleansed the wound. How come I have so much more bacteria? Because saline is just basically washing off the surface contaminant, now exposing all the true bacteria underneath. So you can see the bacteria in a better way. So that's one point. The second point is, by using saline, you're not able to remove the bacteria. Versus using an antiseptic agent, the efficacy and effectiveness of removing bacteria is much better compared to saline. So how do we select the different types of wound cleanser when we think about, okay, perhaps we need to entertain the idea of using antiseptic agent? And we'll come back to that point because I think that's an interesting concept to consider. Usually we don't often link the type of cleanser to debridement, but now there's a new concept called oxidative debridement, perhaps, that can chemically facilitate debridement in a very unique way. And so we have to think about the stability of the wound cleanser and also the clinical evidence available to us. In this paper, they calculated what we call the therapeutic index. Basically, it's the ratio between the mean cytotoxicity concentration for cells over the mean ability for the agent to kill bacteria, to reduce the amount of bacteria in the wound environment. So the higher the number, the better the index, meaning it's more effective in killing bacteria, but at the same time, not cytotoxic. The lower the number, the less favorable is the solution, meaning that the I'm in the show, and I'm going Okay, sorry for the interruption. Internet problem, so technology these days, right? So I was talking about the growing popularity in the use of hypochlorous acid, and I just want to make very, very clear that hypochlorous acid is very, very different from sodium hypochlorite. Sodium hypochlorite is bleach. We use it to wash toilets. Bleach material, very, very toxic. Here is a very high satisfactory index for hypochlorous acid, meaning that it's very effective in moving bacteria. At the same time, it's not cytotoxic. There's no cytotoxicity data that's been reported in the literature. Versus sodium hypochlorite is a very, very toxic substance. So why I keep coming back to talk about pH? Because by reducing the pH level on the skin, perhaps we can promote better wound healing. And you can see in a lot of the papers in basic science, by altering the pH level, making the environment, the wound bed or the peri-wound skin more acidic, you can facilitate the movement of the fibroblast activities. We can increase some of the inflammatory responses to promote better granulation process. So I think it's essential to the wound healing process and also to maintain skin integrity by keeping the acid mantle. So how do we clean in the peri-wound skin? Again, in this best practice document, it talks about 3 different cleansing zones. Depends on the distance away from the wound and also around the wound margin. And zone 2, they describe as about 4 centimeters. And beyond that, then you have the zone 3. And of course, really depends on the size of the wound and type of patient. Sometimes, for example, in this type of wound, I would think the zone 3 in the surrounding skin, it may extend beyond 20 centimeters, and sometimes even 50, 60 centimeters.
da TI que você. Ele está usando o mesmo que a senhora usa, o daquele de professor, está sem a diferente durante.
Mas o meu tem uma interpretação assim. Onde que você vê que é? Aqui são 12 metas, que eu posso ver quanto que está o meu. Aqui vai ter que conectar de novo.
That's great, thank you. And thank you for being so patient with us. So you can see in this picture, we sort of use the term toe flossing to describe how we clean an area between the toes using a moistened gauze and just to really do a good cleaning. You can see the after effect, there's a significant reduction in terms of the amount of bacteria in the area that is involved. So cleansing definitely can make a huge difference. So let me explain to you a little bit more about hypochlorous acid as a key ingredient and why I'm switching my thinking that we should be introducing hypochlorous acid. Your neutrophils, your white cells, will produce a hypochlorous acid in a natural way as a defense mechanism to kill bacteria. So it's nothing really foreign to a body per se, but it's actually part of how your body reacts to bacteria by producing hypochlorous acid. So now they're able to produce this specific ingredient in a solution format. So we know that hypochlorous acid is about 80 to 120 times more effective than sodium hypochlorite. As I said, hypochlorite is weak and is not very effective. Hypochlorous acid can remove bacteria very effectively in many different ways, similar to when you compare to other antimicrobial ingredients. It can bind to the cell, it can bind to the cell wall, it can bind to some of the proteins inside the bacteria and deactivate the bacteria in the end. So this is a nice slide to really illustrate the differences between hypochlorous acid and sodium hypochlorite. So it depends on the pH level. With the hypochlorous acid, it is at a lower pH. So it starts with a very, very similar compound. When it's acidic, then you have more hypochlorous acid. When it becomes more alkaline, the curve dissociates and you create more sodium hypochlorite. So yes, you can change hypochlorite back into hypochlorous acid by making it more acidic again, in other words. So, and this is on the bottom here, you can see that depends on the injuries, the type of injuries, then you can see that as the wound continues to evolve, the area can become more alkaline. And in this case, then you need something more acidic to enhance wound healing and to create an environment that's hostile for bacterial growth. And in this paper, even though it's not really the best type of evidence-reviewed evidence paper, but it talks about the ability for hypochlorous acid to eliminate biofilm and kill bacteria inside the biofilm. And there's a significant log reduction of bacteria observed by exposing the wound to at least about 10 minutes of hypochlorous acid solution. And hypochlorous acid has also been identified as it has the ability to remove denatured protein from the wound bed. And in this case, the terminology, the new term that has been introduced in a couple of documents, including best practice for wound debridement, and also the wound infection clinical practice published in 2022. They talk about oxidative debridement alongside with autolytic, mechanical, sharp debridement, and also biological and other type of debridement method. So it is a chemical reaction that the oxidative agent reacts with the biomolecules, including all the DNA, fatty acids, and all the soft, fluffy necrotic tissue that clips them off and remove them quite effectively. And and we've been actually looking at some, we're part of a group, start really the conversation about what actually needs to be cleaned on the wound. And it's actually a very interesting direction of conversation when we think about what we're removing on the wound bed. So if you look at this picture, the question is, do you think this is a stage 2 versus a stage 3 wound? Let's say this is a pressure injury, because it is a thing, this is a stage 2 or stage 3 problem. Because
the tissue that is there, if you remove that tissue, you will find a little it's more deeper there.
Okay, interesting comment. And a lot of people would think this may be a stage 3. They would say, well, that's slough. According to the NPIAP guideline recommendation, by definition, when you see slough, that is a stage 3. Now, I'm working with the NPIAP to redefine stage 2. So the question is, what is slough? Are you actually seeing slough on this wound? If you can, after cleansing, this is what we see on the wound. So what we actually removed may not actually be slough. What we're removing are the fibrinous exudate. So a lot of exudate may have fibrin, and they can create this gelatinous material on the wound bed. And remember also, there are 2 different layers of dermis. There is the papillary layer, and there's also the reticular layer. So perhaps maybe not in the newest guideline, but in the future, we are going to recommend stage 2A and stage 2B to differentiate the different types of stage 2 wound. With a stage 2A wound, it may be more friable. With a stage 2B wound, when the reticular layer is exposed, usually you may see a more firmer, yellowish wound bed, but not necessarily representing slough. So let's see if we can make it more clear to you in the next year or two, to really bring that to your attention about the differences and the differentiation of various types of staging pressure injuries. So coming back to this picture, what we're seeing, the fibrinous exudate, basically is a type of wound discharge that always have this cloudy yellowish appearance, may contain high concentration of fibrin, but not non-viable tissue per se. And we also know that with the use of hypochlorous acid, with the reduction of bacteria, perhaps we can promote better odor management as well. And we know that smell is a very important component. You know, we're so self-conscious, even among ourselves, when we have a smell, when we have a certain odor. And for wound patients, it's particularly vital because a lot of wounds may emanate a certain type of odor because of the bacteria, because of the exudate. So we actually had done a small study that I talked to a research class this morning as well. We selected about 5 different wounds. We used a scale to evaluate the odor on a 6-point like a scale, in fact, from 0 to 5 by 2 independent nurses. We randomized patients or randomized the wounds to either cleanse with hypochlorous acid first or by saline first. We do a pre and post cleansing odor evaluation by 2 nurses independently, and they're all blinded to the type of wound. We included 3 patients with 5 different wounds, and we have the wounds cleansed, the 3 wounds cleansed with hypochlorous acid, 2 wounds cleansed with saline. And just by using this sort of a very, very small study, we don't think we have the power to demonstrate anything, but we did a small t-test anyway. We're able to demonstrate a significant difference in terms of odor reduction over time, and there's a significant difference between the two groups, between the saline group and the hypochlorous acid group. So I'm going to speed up a little bit because I know it's in the interest of time. The last thing I want to share with you is a instrument development. The purpose is to focus on describing the severity of MASD. And when we look at first we looked at the literature and see what's out there. Can we actually use something, adopt something, adapt something to our use? And we found actually a variety of different tools. We don't want to just focusing on IAD instrument because MASD is a more umbrella, broad term that we should have a tool able to use across different types of MASD. And when we looked at the literature, there are different types with IAD, the globiate, and a lot of my Brazilian colleagues here, they're quite familiar with the adaptation and the use of globiate already. And there's also some other type of tools that have been developed to evaluate the peri-wound skin MASD and also the intertrigo problem. But what we know is a lot of the tools, they categorize the different types of problems, different types of MASD, different types of incontinence problem. They don't describe the severity on a continuum. So if you think about a continuum, it's like from 0 to 10, with 0 no problem, 10 is a very severe problem. So that's why we want to challenge ourselves to develop a more sensitive tool, because by implementing intervention, you should be able to see changes fairly quickly over time, over a short duration of time. You may not be able to change from one category to the next category, but there should be some early signs of resolution or improvement of the skin, indicating that we're moving in the right direction. So that's why we recognize the deficit in the existing instruments available for us to determine the responsiveness of the injuries to treatment. So based on the literature, we create a few metrics to include in the MASD tool. So just to describe to you the process, we look at all the literature. We try to be as comprehensive as possible when we look at the variety of literature out there. So this is what we come up with in terms of the tool. So we're going to describe the size of the area involvement. There's skin changes, under skin changes. There's maceration, erythema, rash, edema, induration, and weeping. And then also skin breakdown, lesions, erosions versus blistering, and also patient symptoms, whether they experience pain or pruritus. So, and we're still in a very early stage in terms of developing this tool to evaluate the psychometrics. Love to hear comments from this group, whether we're on the right track, whether you think some of those parameters actually make sense to you, because we want to apply some of those metrics for the different types of MASD, not just for IAD or not just for peri-wound skin damage, the different versions of moisture-related skin damage. So you can see that along each parameter, we can actually rate the severity, whether maceration is 0 for none, 1 for mild, 2 moderate, or 3 severe. So then you can actually, at the end, come up with a composite score to indicate how severe and convey to other people how bad the MASD is. So this is our approach, and we actually adopt a standardized validation process. It's called the RAND, developed by UCLA. What's involved is, with each criteria, we ask people to rate the 2 questions, whether the parameter, the metric, is considered to be appropriate and also whether they consider to be necessary. Because if you think about maceration, it may be appropriate, but some people may think they're not necessary to be on a tool. That's why with the RAND method, we evaluate the two aspects, appropriateness and the necessity to be included in the instrument. And based on the sample size, we can come up with the percentage and determine the level of agreement. And there's some sort of fancy calculation involved in determining why those numbers are the standardized way to determine the level of agreement. But anyway, I can show you some of the outcomes included in a tool like this. There's a little bit of debate about, what the size should be. We don't want to be limited to too small or too big a size. Erythema, on the most part, we have achieved consensus. Rash is a very interesting one. We thought that we should be able to have a lot of buy-in, a lot of consensus, but we see a little bit of variations there as well. Edema, there's a little bit challenges. Induration and pain, definitely. There's a very high level of agreement. And also providers. Yeah.
Sorry, for Juliana.
Oh, okay.
Sorry again.
That's all right.
Sorry.
We're out again.
Juliana's iPhone.
2025, but here
The first one. Juliana's iPhone.
Oh, yes.
MAEDA.
MAEDA.
1, 2, 3.
Okay, continue on. I'm almost finished, so bear with me for a few more minutes. And we're also in the process of developing some of the consensus statements along with the tool instrument that we're developing. Love to hear your feedback and comments about the utility of this type of tool, whether there's a need. We've been getting, we presented this tool to our local association meeting, and there's a lot of good feedback, and people asking us whether we can start using the tool. We keep telling them, well, not quite yet, because we need to test to rate the reliability and establish better validity. Even though we have the content and the phase validity, we need something better. So you can see that, for example, in this wound, in this MASD problem, you can actually rate the skin and using the tool like this. And I think we can see a little bit maceration, even though it's covered by some zinc oxide, and a lot severe level erythema. There may be a little bit rash, maybe moderate, and there's quite a bit of edema, induration, and some weeping going on, and it's quite painful for the patient and also quite itchy. So now you can see that if you summarize the score, it's very severe. You can come up with a high score, versus now with treatment, you can see that there's some improvement already, but it's still in the same category for IAD. But we're able to reduce the moderate amount of maceration, less severe erythema, and we can see the rash is not so bad, less level of edema, less induration, and less weeping on the skin. And then at the end, you can see the skin is almost healed, and all the problems have resolved. So by using the tool, then we're convinced that we're able to promote better documentation and better evaluation. And the final thing that I'm going to show you, I think Giselle is interested in using some of the device like this for his research as well. So basically, it's a new handheld machine that Canadians have developed. What you can see on one side is a screen. On the back of this device is a light bulb. The light bulb can produce the near infrared light and infrared light. The infrared light is able to check the temperature, to evaluate the temperature level. The near infrared is able to produce the calibration of skin perfusion, oxygen level. Depends on the type of wavelengths, the different types of light, whether it's near infrared or infrared. So by shining the light into the skin, and the computer system inside the device is able to collect how the light is being reflected from the skin. So you can tell the skin temperature, the oxygen level on the skin. So let me show you how it's being used. So this is the size of the device, and I'm calibrating it, entering the patient data to take a picture. So with our patient, I'm using my hand, so I can actually, at the right distance, and there is a ruler to tell you where to position the camera. So I took the picture, and after the picture, then it's being computerized and calibrated by the computer inside the machine to produce an image that you can see. What you can see here, the different discoloration telling me the temperature and also the oxygenation. So red, the top picture, is good. I got lots of oxygen on my fingers. And the blue color is good on the below picture. It means it's warm. So you can tell actually using a handheld device by doing so to look at potential for wound healing, whether there's enough oxygen, whether there's any ischemic damage. And we're actually in process of doing a study to evaluate using this machine, following patient from admission to capture all the skin changes over time. And by doing so, we can teach the machine learning to identify, to detect early skin changes associated with pressure injury, or MASD. So again, you can see that this is a real patient that I took. His wound on his foot area on the metatarsal head. And what you can see here is there's not a lot of red color. You see lots of blue color indicating the lack of oxygenation, especially in the area where there's necrotic tissue. There's only 36% there, 50% there. Going back is about 21%. So very, very low level of oxygenation. And you can also check the temperature by tapping on the screen, because all the data has been calibrated inside the computer. You can actually see the temperature 30 degrees there, 33 degrees there, 33. So the more distal area is cooler, indicating perhaps there's a lack of oxygen, lack of blood flow to the area. So I think maybe perhaps I'll stop here because just a few more slides about MARSI, and just to see if you have any questions or feedback about our discussion. Too many questions? Okay, I'm going to stop screening, my sharing.
How much this device, Kevin? I need to question about the cost.
It is
the name
mimosa.
Appeared in many types of drinks.
It is a fancy drink. Yes.
Then it appeared.
Yeah. It's quite expensive at this point because they just developed the product. just like when you have a new product, it's always more expensive until you can mass produce them, right? So I think at this point it's about 30,000 Canadian. 30,000. I know it's going to drop once it's become more popular or being adopted by different people. But I'm more interested in terms of the technology, how artificial intelligence will be able to help us detect pressure injury at an earlier time, even way before we see an invisible sign. Even ultrasound may not be able to as sensitive to some of the skin changes we see. Yeah.
If you put some ointment or any,
It's not going to affect.
doesn't affect.
No. Yeah. I mean, if you put a thick layer of zinc, it will affect the effectiveness because you cannot penetrate through the skin into the bloodstream. So something like a regular moisturizer is not possible. Yeah.
Are there any students using the Marshall program?
We're currently doing a study. There's some sort of preliminary study that I'm happy to share it with you. Yeah.
We are
Scanner. Yes, I think there's some very good studies by Dr. Jensen in the United States indicating the ability to detect early stages of pressure injury. But I think the type of machines that we have may be able to detect different types of skin problems, not just pressure injury, but also to help the machines recognize, for example, skin tears, for example, MASD, and other types of problems. So I think the SAM scanner is good for pressure injury, but there's no indication.
Microphone. We have some questions in chat. Try again to listen.
Só que o pessoal está falando aqui. Voltou.
Yes. Because there is a gap in the transmission. How can universal screen and treatment bundles prevent skin injury when pH varies unpredictably by age, site, occlusion, and alkaline salts?
Okay. How?
How can universal screening treatment bundles prevent skin injury when pH is unpredictable by age, side of
Yeah. That's a good question. I think the point I'm trying to make is instead of having, I think we're entering into age of specialization. Everyone wants to develop their own tool. Everyone wants to develop their own screening material. So in my practice, sometimes we have to ask nurses to use a braided to screen for pressure injury. We have to use another tool to screen for skin tears. We have to use another tool for MASD. We have to use another tool for other problems, for falls. So you end up using maybe 3 to 4 different tools to evaluate skin problems. Nurses have no time, right? So, and they have common risk factors: malnutrition, pressure injury, malnutrition, skin tear, malnutrition, MASD, moisture, everything, right? So why are we wasting nurses' time? I shouldn't say wasting, but I think the tantalizing idea is, can we come up with a more generic approach to identify patients at risk for skin injuries and looking at this continuum of injury problems. And once they're identified, we can implement different interventions to prevent pressure injury, prevent skin tears by using a skin bundle. The skin bundle basically are the same: activity and mobilization, nutrition, hydration. If you have adequate hydration, you can reduce skin tears, you can reduce pressure injury, you can perhaps help MASD as well. So I think we have to be smarter in terms of the way we create tools and promote practice. It's nice to have research from a research perspective, individual instrument, but from a practice perspective, we may not be serving ourselves in the best way to have so many, to silo all these conditions. Yeah, so I'm glad that I got some nodding here in the audience agreement.
I think it's important to have that information, but we need to improve the clinic.
Yes.
Clinic thinking.
Yes.
The clinic thinking to the nurses.
Yes.
Because we don't need to be so only one instrument and things like that. We need to understand how the people works and things happens to improve the way to treat and things like that. So many times we are searching only one tool for this, but it's the base is the same.
Yes, I think you put it very, very nicely. We need to open up that scope to be able to include more inclusive and not just focusing on one problem alone. Yes.
And also, we need to think in the time to save the time of the nurses. When you are in the hospital, treating patients, you don't have time. I am thinking in the tool of Moises 33 points. This is from 0 to 33. How much time it takes to the nurses?
Well, hopefully not too long. I think if you look at the skin, you can just check out the boxes, and in 5 minutes you should be able, the most, I would think, to identify, is there any erythema? If there is erythema, do you think it's mild, moderate, severe? And just circle it and check off the box. I think it's, well, from my perspective, I'm biased, of course, that it's easy to use and friendly to use, and able to produce a score to reflect how bad MASD is. Because when you say, oh, this patient really, really bad MASD, and I could picture, okay, what is bad versus what is okay MASD, right? And now we have maybe a way to describe, quantitate the severity, so to speak. Yeah.
Thank you. what type of study could be used to evaluate the use of Pro for the early detection of the different types of wounds?
The method to evaluate different types of wounds.
Because the specific injury is, I think that one machine for detecting early injury, but possible with the Mimosa Pro is many possible. So that thing is possible the evaluate several injuries with the Mimosa Pro, but maybe problem because of the very several injuries. Understand?
I do. Thank you so much for that question. So I think we have to be careful in terms of what we want the machine to do. Even for us as human beings, by looking at the wound, we may not be able to come up with the diagnosis. Whether it is malignant wound or non-malignant, there's no way you can just visualize it, say this is cancer versus non-cancer. You need to take a tissue biopsy, look at under the microscope. So in other words, there's limitation in terms of what the machine can do by looking at the presentation of the skin. Yes, you may be able to add, thermometry, looking at the oximetry level to determine oxygen and blood flow. But still there's limitation in terms of looking at the histological changes of the skin lesion to determine the exact diagnosis. So there is a limitation. So I don't think, at least today, with the artificial intelligence available for us, able to make that differentiation. Who knows? Maybe in future, in 30 years, with the movement, with how technology is moving along, they may be able to identify, come up with some kind of biomarker or collect molecules from the wound or from the skin to determine the exact type of wound. But I think it still requires clinicians to take a very good history to determine what type of wound it is. Because you cannot just look at the wound and say, yeah, this is pressure injury. Or look at the wound and say, yeah, this is diabetic foot ulcer. Who knows whether the patient is diabetic or not? So until you ask the patient to get this understanding, yeah.
But it's possible is did you take in the group of types the injury? For example, injury pressure, dermatitis associated, incontinence associated, and skin tear. It's a group. It's common in my press. Não estou comentando, estou perguntando. Understand?
Yeah.
So that I think that it's possible to research these three injuries.
Absolutely, that's exactly what we're doing. So we're hoping the machine will be able to differentiate stage 1, 2, 3, 4, and stage 4 and DTR. We're hoping that we're able to using the machine to differentiate stage 1 from MASD or stage 2 from MASD. So my hypothesis, I cannot confirm quite yet until we get all the data, is when you have pressure injury, you may have stage 1, you have the erythema, but you have a low oxygenation because of the pressure. So there's poor skin perfusion and maybe lower temperature. Versus at MASD, you have the erythema, but because of the inflammation, so you got an increase in temperature and increase in perfusion locally. So by doing that kind of calculation using we'll be able to teach the machine how to calibrate based on the information collected by the visual presentation and the temperature and the oxygen to come up with the calculation, and we can separate stage 1 from a erythema because of MASD. Maybe I'll come back to tell you next year. Well, maybe too early. Following you.
Professor Kevin, we have some questions from the chat. The first is about the recommendations you show us.
Yes.
If it is recommended for newborns or not.
Newborn. Which recommendations?
Maternal newborns, right?
Yeah, but they don't indicate which recommendation. I think in general, if it is indicated for newborn or not.
I would say no, especially with the use of antiseptic agent. Definitely, I don't think there's a need for introducing antiseptic or antimicrobial cancer to newborn. Especially, we don't want to disturb their microbiome and the skin flora because they're still actually developing the bacteria on the skin.
And we have more 4 questions, so I will ask about the short one and the big. I will ask you after. Do you recommend the use of laser therapy for IAD or not?
Laser therapy. I'm not so keen on using active therapy, energy therapy for a inflammatory skin problem. I honestly, maybe the honest answer is I don't know for sure because there's no studies being done using laser therapy for the management of IAD. I would think this is a little bit of an overreaction because it's a very expensive modality, and of course, if you have the light and you have the time, perhaps it's worth the study to pursue the effectiveness of using laser therapy. My immediate reaction is it's not going to be extremely productive because the better thing to do is to stop the irritation and looking at how we can protect the skin better.
Okay.
Yeah.
Thank you. So the next one is, what the recommendations are for preventing skin injuries in the genital area associated with the use of systematic antibiotics after a surgical procedure?
Right, so to protect the intertribal problem after antibiotic use, after surgery, we see those patients very often, we see those problems very often. There's some studies indicating that perhaps, prebiotic, probiotic perhaps could be quite useful just to replenish your flora. I think the main thing is ensuring there's good skin hygiene. I think going back to that basic concept, and good skin ventilation to allow the skin to breathe a little better. And that's why when you use the surgical dressing for incisional care, we advise some semi-occlusive, non-total occlusive type material to enhance some airflow.
Thank you again. So would it be available with hypothesis to consider elevated Charson index and PCR as indicating a higher risk of developing MARS? Is a question. And what other biomarkers could be considered in screening?
Biomarker for screening for MASD?
For MARS.
For MARS. MARSI.
Yes, MARSI. Sorry.
I don't think there's any good biomarker published out there for MARSI or even for skin tear. Not that I'm aware of. You're on ISNAP, you might be more well aware of the most recent literature. There's some proposed biomarker for pressure injury, like some of the inflammatory markers, but I think they're correlational rather than predictors for pressure injuries. So as far as I know, there's no biomarker at this point that would be able to help us with the prediction. I would think perhaps patients with low albumin level, with low protein, at high risk for developing skin tears and MARSI because they tend to have edema, they tend to be malnutrition, but I don't think there are biomarkers per se.
And the last question from our chat is from our colleague Fernanda. She is a member in this group. She give you a kind message. There, Professor Kevin, you always provide us with updates and innovative concepts. The update on pH management was excellent. Would it be possible to provide us with the reference of the study on odor control using hypochlorite? HO, yeah. Please, I would like to read about its applicability for odor control in fungating wounds.
Okay, yeah, I'm happy to provide all the references.
So that is our questions. So for YouTube, we will end this transmission. So thank you to be with us today. I'm so sorry for our internet issues today. Bye-bye. Have a nice weekend.
Bye-bye.